The overriding approach is to drive the agenda for universal health coverage. And I think that the aspects of interest to this conversation, which is, some of the causes of women death, with the technology and resources and knowledge currently available in the world, those can be dealt with. There are particular cancers and difficult conditions for which we, as a medical fraternity right now, may not have solutions for. But there are things for which solutions do exist. And so from the government sort of policy framework is to make sure that you avail access to health care to as many people as possible, and insurance is one mechanism. Now, I alluded to the fact that the health insurance scheme as we have it, it's just born now, and we're trying to push it further. But the challenge has been that it is insufficient. The models suggest that for a population of almost 20 million, you do need 4 to 5 million direct contributors in order to meaningfully cover everybody. Unfortunately, the fraction of meaningful contributors is obviously much lower, and there is a gap there. Something else that the government has done, which I didn't get an opportunity to share, is actually just last week, the minister was signing a statutory instrument that requires that from that, the collections of the health insurance scheme, there's a specific drug fund. And in that drug fund, it's also an open basket that can go to support further commodities that may be lacking in the interest of providing general care. But the key issue really for surgical interventions is that we've got to make sure that the basic surgeries that for which the techniques have been known for years, that those are available to the people when they need them. And the issue of women bleeding to death during labor, I think that there is enough knowledge to stop that. What we do need to manage is a frame where colleagues like Dr. Makasa work through the processes and procedures to guide the colleagues more in the grassroots level. And we also have an investment into telemedicine facilities now that surgeries in the more peripheral places can be supported remotely or even physically by having experts move in for the elective one, the things that are planned, move in and support them on the ground to do that. But key is the sustainability question, the structure that the government makes sure there are people who are being trained constantly to take up that responsibility in the districts and the more remote places, so that these procedures, to the extent possible, are domesticated. And then you only leave the more technical and more maybe complicated surgeries to move upwards to the tertiary facilities where you have the Makasas and them to handle. But I think that we need sort of a structured frame in which basic life-saving surgeries can be facilitated countrywide. And I think that is possible. And I think that it can be conceived in a way that you begin maybe with several districts or a couple of provinces and other districts in there, pilot it, learn lessons from there, and see how you scale it up. But I think that in a reasonably short period, you can have a concept proved very successfully and really have a model that perhaps can be scaled up and other countries learn from. Let me end here. Thank you.